Lovely. I'll leave it over to Keisha.
So me and Alex are going to present the presentation on the ANDROMEDA shock trial, which was from 2018, and it looks at the effect of resuscitation strategies targeting peripheral perfusion status, so i.e. cap refill time, versus measuring serum lactate amongst people with septic shock. So just a bit of background about sepsis. So annually around 245,000 people develop sepsis in the UK. And unfortunately, 48,000 people die of sepsis-related illness. So because of this, a few years ago, the Sepsis 6 was introduced, which most of us know. It's taking oxygen, well, giving oxygen, taking blood cultures, measuring lactate, giving fluids, broad-spectrum antibiotics, and measuring urine output. And that actually has caused an increase in survival from 70 to 80% with improved awareness of the condition. And the Surviving Sepsis campaign advises us to measure and then normalize serum lactate, which becomes relevant as we go through this study. So the question this trial aimed to answer was, in the adult population with septic shock, does peripheral perfusion-targeted resuscitation compared to lactate-targeted resuscitation improve all-cause mortality at 28 days? So this study was a multi-center randomized control superiority trial. So there were 28 centers recruited across 5 countries in South and Central America, and patients were recruited over 1 year in 2017 to 2018. They either got allocated to the cap refill time arm of the study or the lactate measurement arm of the study, and it was a computer random allocation. Clinicians weren't blinded, and they used intention to treat analysis in the when they went through the data. So the population cohort were adults over 18 years old. Eligible patients were people who were confirmed to have septic shock either with the following criteria. So they had to have a suspected or confirmed infection, lactate had to be over 2, and they needed vasopressors to maintain their MAP despite a significant fluid bolus. And the patients were recruited as early septic shock patients, so they had to be recruited into the trial within 4 hours of meeting the 3 criteria for septic shock. There was some inclusion criteria, so people with ARDS, active hemorrhage, dialysis-dependent patients, people who had DNAR directives, if they were pregnant, liver cirrhosis, or acute hematological malignancy. So that left 424 eligible patients. So across the 5 centres, there were initially over 1,300 patients who were assessed who could be eligible. However, about 900 were excluded for various reasons, such as DNARs, acute hematological malignancy. There were 102 people who weren't enrolled for other reasons, but it's not specifically clear why they weren't enrolled. So that left the 422 who were equally split between the peripheral perfusion capillary refill arm and then the lactate arm. So when we look at these 2 groups of patients, they have very similar demographics in terms of age, their SOFA score, and their sources of sepsis. So I think the 2 groups were comparable in this study. So once they were allocated to the different groups, they were then followed up differently. So in the cap refill time group, they measured their capillary refill every 30 minutes and then hourly after normalization. And the aim was to get a normal cap refill time, which they classed as less than 3 seconds. The way they standardized people measuring capillary refill time was that pressure was applied to the right index finger with a glass slide. It was held for 10 seconds till the finger blanched, and then they timed how long it was till color came back. Now, if you're in the lactate group, you had your lactate measured every 2 hours for 8 hours. And the aim was to either normalize the lactate or have a decrease by 20% every 2 hours. So if you started off with a lactate of 10, after 2 hours, you'd want it to be 8 or less. And if patients weren't meeting their proposed target on whichever arm they were, the clinicians followed the following treatment algorithm. So the initial first stage was checking if they were fluid responsive, either by passive leg raise or pulse pressure variation. If they were considered fluid responsive, they were given more crystalloid boluses to try and achieve their target cap refill or lactate. If that was ineffective, then it was use of vasopressors. If patients were chronic hypertensive, they tried to aim for a target tire map of 80 to 85 to see if that helped them meet their target cap refill or lactate. If that was ineffective, the map was reduced back to a target of 65. And lastly, if that wasn't effective, then inotropes were introduced.
Okay, so these are the results. The primary outcome that they looked at was 28-day mortality, and that was higher in the lactate group. So it was 43.3% in the lactate group versus 34.9% in the capillary refill group. Notable secondary outcome, so the only other secondary outcome that was significant was that about 500 mils less of fluid was given to the CRT group, and less adrenaline was used in the CRT group. And we will talk about the other secondary outcomes that were looked at, but there wasn't any significant result in those. Was Dr. Chennai raising a hand there? Sorry.
I wanted to know.
Carry on.
We can't hear you.
You hear us now?
Yeah.
Yeah, we can hear you.
Okay, I just asked the question whether they used, you said the inotropes which were used were dobutamine and mildred, or did they use adrenaline as well? Because you say less adrenaline in CRT group, but what is it? Is it the inotropes? Yeah.
Yeah.
So that was the algorithm that was set out, but at clinician discretion, they could alter it if they needed to. So adrenaline wasn't in their treatment algorithm, but if clinicians felt they needed to use it for their patients, they did.
Okay, then in that case, my question comes with adrenaline usage. What happened to that lactate arm group? Because it will raise the lactates. Okay, right, carry on. We'll come to that in a bit.
So yes, here we have the secondary outcomes. So organ dysfunction at 72 hours after randomization, and that was on the SOFA score. How long they were mechanically ventilated for, renal replacement therapy and vasopressor 3 days, and that's within 28 days. Total length of ITU stay and total hospital length of stay as well. And I think they looked at 90-day mortality as well.
That's the tertiary outcome.
Yeah. And this is a slide of the results, which I'll just leave there. No, not a huge amount of difference other than in the categories that we've already mentioned. This is a little summary slide. So obviously outlining the population as discussed, locations, the intervention, so 424 patients to 212 on each side, the main primary outcome and the main finding, which was all-cause mortality at 28 days. And we've got a little picture of that graph there. So that's a hazard ratio of 0.75 for CRT-guided resuscitation versus lactate-guided. Now, we'll come on to it, but those results are not statistically significant. And I will talk about that now. So the good things about the trial, they pre-published the protocol and the analysis plan. It was a multinational randomized control trial. There was no loss to follow-up at all. And CRT and lactate are already used in ITU and in the emergency department, and it's a clinically relevant study to be doing. However, as I said, the study resulted in, well, as I said, a hazard ratio of 0.75 or a mortality difference of 8.5%, which may sound like a lot, but it didn't meet the p-value of 0.06, and there was a high probability of a T2 error, so false negatives. And that makes sense when you think about it, because actually, for this kind of intervention, though, those kind of numbers would be huge. It would suggest a number needed to treat of 12 for CRT-guided resuscitation versus lactate. And when you think about it, that doesn't really make sense. There's questions about bias in the trial. So 100, as Keisha mentioned, there were 102 eligible but not enrolled. And it's not totally clear why this was. So this was a quarter of the total patients who were enrolled. And this is bearing in mind that the study was already underpowered for what it was testing. So some fairly large concerns with the study there. Having said that, the probability of a type 2 error was addressed in a Bayesian analysis post hoc 2019, and it suggested that, well, it supported the findings of a reduction in all-cause mortality with perfusion-targeted resuscitation. And perhaps more interestingly, it suggested the original paper's findings could be for two reasons. So one of those reasons is that less fluid was given with perfusion-targeted resuscitation. And another one, which you may have picked up on as we went through it, is that perfusion-targeted resuscitation was done more regularly compared with lactate monitoring. So obviously that requires looking at the patient more often, which may have affected the outcome. This leads into a broader question, I think, well, a couple of broader questions, but one of them is about sepsis and the management of sepsis. So obviously at medical school and as doctors, we're encouraged to remember and use the sepsis 6 because it saves lives. And one of the sepsis 6 is to give fluids. And perhaps a question raised here is, are we giving too much fluid in sepsis to the point of detriment to our patients? Another thing to think about based on the study is what would cause a raised lactate. So as you may well be familiar, there's a type A lactatemia and a type B, and type A is related to increased production, and that can be from hypoperfusion, anemia, but it would have to be very severe anemia or very severe respiratory failure, or seizures, and type B, which is related to a reduced clearance. We see that in liver failure, kidney failure, and with certain drugs. We know that sepsis is associated with a raised lactate. As far as I can tell, there's some debate as to whether that is an anaerobic production of lactate, which would be secondary to poor oxygen delivery, or whether it's an aerobic production of lactate, which would be as a result of, again, from what I found online, increased beta-2 adrenergic stimulation, and therefore pyruvate metabolism. So an excess of production in that respect, and that's in a similar way that seizures cause a raised lactate as well. So clearly, and we're extrapolating a little bit here, but if lactate is raised, but perfusion is normal, then the temptation is to chase a raised lactate with fluids until it comes down. And as I say, I think that feeds into a more recognizable intensive care debate about the value of normalizing numbers just for the sake of it, which can sometimes be tempting, as I say, may not always be the best thing for patients. So to conclude, it is a relevant study, but it is fundamentally flawed. In terms of design, it was underpowered, and there were opportunities for bias as well. It does, however, raise questions which are still being asked about the best way to manage sepsis. So, for example, should we be giving so much fluid? I know that some clinicians would recommend going to vasopressors straight away, because they say that because the shock is distributive, it's not actually a problem with volume. It's a problem with keeping that volume in the right places. And I think the other question, as I've said, is about to what extent we should be treating numbers, to what extent we should be chasing a lactate. As I said, in terms of how it's going to change our practice, personally, it will make me a little more attentive to doing a CRT on a ward round or assessing a sick patient, whereas perhaps I may not have been in the past. I don't think on a large scale it's going to dramatically change intensive care practice, and that's because when we assess a patient for how well filled they are, we're using lots of things. So we're using a lactate, we're using a CRT. You could be using a cardiac output monitor. You could be using ultrasound. You've got a wide range of tools on intensive care to assess that kind of thing. This study may have more of an impact in areas where arterial lines are not in use. So on the wards and perhaps in other countries or areas where that's not available. I think that's it, and we're happy to listen to any questions.
Guys,
oh, we can't hear you again. Sorry.
We are just unmuted. Anyone has a question? Okay, so I wanted to ask you, what was the study which was done? I don't know where it was done. I missed the initial part.
Yeah.
What was the rationale behind choosing capillary refill time as a comparative thing? It's the first thing I wanted to know.
This was done across South and Central America, and it does say in the abstract that they acknowledge that in some areas you may not have access to regular lactate measurements. So I think it was to see in resource poorer areas, is cap refill just as good or better than lactate?
Okay.
Trying to manage these patients with septic shock.
Okay. Then the second thing comes to my mind about why, was there any inter-observer variation when they are doing this capillary refill, especially they chose the nail bed, and whether there was any inter-observer variation and what kind of adjustments they made to that, which is my next question.
So that was a concern for them, inter-observer variation, and they did acknowledge that. And one of the steps that they took was, I think it's described as half an hour and an hour long presentation or kind of a teaching session on how to take a cap refill. And they did that in an attempt to normalize or standardize the way that observers were doing it. And to what extent that was effective, I'm not sure. I don't know if they commented on that, but there was concern, actually, I saw somewhere, that because they'd had this teaching session, that actually perhaps they'd be too well trained in that regard, versus or too attentive in that regard, versus simply taking a lactate.
Okay, and then my final question is about why they only stuck on to the peripheral CRT and not doing the central CRT. Did they find anything like, in the terms of, was it good enough that they thought that peripheral CRT is sufficient rather than a central CRT? Because you could have some variations with the peripheral and the central CRTs in quite a large amount of population.
That's a good question. Again, I'm not sure it's one that they addressed. And that, when we were thinking about the presentation, actually, and we were thinking, so we thought about causes of a raised lactate. We were also thinking about causes of a prolonged CRT peripherally. And obviously, you're thinking about things like peripheral vascular disease and Raynaud's and that kind of thing. And in that regard, yes, it may have been wise to have done a CRT as well, but then I think that might have complicated the study. And I think part of what actually works well for the study is that they're saying it's such a simple intervention. I feel that maybe if they'd done a essential one, it would have helped, but it also might have muddied the waters as well.
Okay, all right, thanks very much.
I have just one thing to say. There was, in early part of the last decade, they did some studies to compare lactate versus lactate clearance as a predictor of, marker of sepsis. And a lot of studies found that lactate clearance was a better marker as compared to lactate per se. So it just made me wonder, now we are in this decade, and why these researchers thought of using lactate in their studies rather than, lactate clearance, which is a better marker, is all I can add.
I think it may come back down to, again, where the study was done and about resources, potentially.
Also the fact that on the wards and on ITU, people use lactate all the time, and they use it as a measure of end organ perfusion. So I think it's probably testing this easy intervention against something which is widely used. I'm sure you're right, and I hadn't heard of the lactate clearance, and maybe that's something we should be using. But obviously, everyone knows about lactate, and people measuring lactate. As I say, it's in the sepsis 6. So yeah, I think that's what's in use. So that's what they were comparing.
Do you know if there was between the two groups, did they keep a track of the other interventions that they had across the group? So Dr. Snow was saying, the amount of adrenaline used, or you said they used more fluid in the lactate group.
Yeah.
How about the rest of the interventions? Were they more or less the same between the groups? What did they say?
Do you want to go?
I was going to say, so things like with the fluids, it did say on average that 500 mils of fluid less was used in the CRT group. I don't think they specifically said how much less adrenaline, just that less adrenaline was used, but I'd have to go back and read look at the breakdown of the study again.
Oh no, sorry, I didn't mean specifically though. I just meant in general, was there a table to say, in terms of other interventions used, basically to keep it so that the only difference between the groups was the cap refill versus, there was a table, okay, cool. And was it more or less the same, I guess it probably was.
The main difference that I read about was, and the one which people picked up on, was the 400 mils less
Okay.
in the CRT guided group.
And otherwise the interventions are more or less the same, I guess.
Yeah, I think so.
Yeah, no, that's fine. I just wondered if they kept a track of it rather than, and it sounds like they did.
And I'm quite surprised that the study where it was done, you think that there are probably some resource limited areas or something like that.
Sorry, you're fading out. I'm not sure.
Oh, okay. Now what I'm saying is the study which has been carried out in whichever part of Central America, where you think probably this was initiated on the basis of resource restriction, and they wanted to look at capillary refill time as a kind of an alternative comparing to lactates. But they have been using milrinone. Milrinone is a very costly drug. We don't have it. It's a good antidote, but we don't have it. Yeah, we don't get an access to the milrinone. It's never easy in UK. It surprises me that they could use milrinone, but they have to resort to capillary refill time. Good presentation, by the way. Thanks very much for doing that. Very well done, guys. This is from JAMA, is it?
Yeah,
Yes.
JAMA.
JAMA. Excellent. Good, good.
Lovely.
Good
Thank you very
pick.
much.
Thank you.
Okay. And sorry, before I close down, if anyone else wants to have a question or something.
Thank you. Very good.
Thanks, guys.